Thank you for joining iMeet. This meeting is now being recorded.
Good evening, everyone. I'm Krishna coming to you from Loma Linda University, and on behalf of my co-moderator, Dr. David Shah from Harbor, UCLA, we're excited to welcome you to another highly anticipated edition of our AABIP webinar series. Now, before the formal introduction of today's topic and speaker, I'd like to review a few housekeeping matters. First, everyone please note that this webinar will be recorded. It, along with previous and future webinars, can be viewed on the AABIP website and can be found under the Education and Training tab on the front page. Second, we ask that all participants mute their phones during the course of the webinar to minimize background noise and optimize the overall listening experience. Alternatively, you can use the volume control icon at the bottom right of the iMeet window. Now, to ask questions or communicate with the group during the webinar, please type them in the chat box that you can access by clicking on the thought bubble icon located in the bottom left of the iMeet window. Now, we leave it up to the presenter to answer the questions as they appear during the talk, but we will keep track of the questions as they come up and have the opportunity to address them toward the end of the hour in a formal Q&A period. So please feel free to type in your questions at any time. Also, in the bottom left is a projector icon. This allows the audience to toggle between the presenter slides and any videos. Now, finally, a couple important disclaimers. The AABIP does not endorse any specific technologies or products. Also, the content and views expressed within the webinar represent the opinions of the speaker and do not necessarily reflect those of the AABIP. So without further delay, I'd like to turn things over to Dr. Shah for our formal introductions today.
Thank you very much, Ara. So today we are very pleased to have Dr. Ganesh Krishna join us. He's going to be talking about patient selection for bronchial thermoplasty, who and when. For those of you who do not know Dr. Krishna, he is an associate professor of medicine from University of California, San Francisco, where he is not just an interventional pulmonologist, but also the director of their interventional pulmonology fellowship program. So thank you very much for joining us today, Dr. Krishna. We really look forward to hearing your experiences with bronchial thermoplasty.
Thank you, Dr. Shah. Thank you, Dr. Krishnan. And thanks, everyone, for joining us this evening for this discussion. Today, I will talk to you about bronchial thermoplasty, when is the appropriate time to do the procedure, and what kind of patients are suitable for the procedure. So just to start with little disclosures, get it out of the way, I have a speaker agreement with Boston Scientific and consultant agreement with Boston Scientific. However, this talk is not supported by any of the industry and no specific financial conflict of interest for this presentation. Just to give you a brief overview of asthma. Asthma is a disease, as many of you know, is characterized by airway inflammation, bronchoconstriction, and mucus hyperproduction. And it is difficult to discern which aspect of the pathobiology of asthma is dominant in any particular asthmatic. And oftentimes, it's a mixture of a few things. So this cartoon actually shows on the left side a normal bronchiole and an asthmatic bronchiole on the right-hand side, showing the redness, which is inflammation. And as you can see, the bronchoconstriction with luminal narrowing and hypertrophy of the smooth muscle causing that constriction, and mucus in the lumen of the airway. This is a clinical classification proposed by the National Heart Lung Blood Institute guidelines published in 2007 based on symptoms of cough, wheezing, tightness, shortness of breath, and nocturnal symptoms. And in addition, peak expiratory flow rate variability into mild, intermittent, mild persistent, moderate persistent, severe persistent asthma classification, depending on the frequency of these symptoms and the severity of these symptoms. There are several contributors to poor asthma control. people are exposed to environment that is not agreeable to their lungs, including seasonal allergens, constant exposure to allergens that are present throughout the seasons, airway irritants such as smoke and dust, and viruses, which also cause intense airway inflammation and exacerbate asthma. And many of you know that people with asthma are more, or respond more vigorously to viral infection with asthma exacerbation and respiratory insufficiency or failure. Comorbidities such as upper aerodigestive tract contribution in the form of rhinitis, sinusitis, acid reflux, and obesity, which may be a factor in worsening acid reflux, are all things that need to be taken into account when we manage an asthmatic patient. Improper technique is oftentimes under-recognized, but a very important factor in how asthma gets controlled. There are, as technology develops, there is not just jet propellant inhalers, but also various other types of inhalers, and it is not easy for a patient to be familiar with the different types of delivery techniques, and that is one of the factors responsible for poor asthma control. Of course, compliance is a factor in terms of adherence to treatment regimen, proper use of medication, and access to health care is another factor that will affect asthma control. Dr. Shah, is there a way I can minimize the participant list on the left-hand side? Is that something that you can help with? I'm not able to do that.
Yeah, just go ahead and click on that icon, and it should minimize of the participant list.
On the icon. Oh, okay, got it.
Click on the actual icon of the participant list.
I got it. Thank you. So cost of the medications, inhalers cost a lot of money, especially in the United States, and in patients with fixed income, this may be a problem for them to getting these medications. So all of these factors have to be taken into control. Access to health care is another issue, as we all know. So this slide actually is a little bit busy, but it actually proposes a stepwise approach in terms of medications that are used that is appropriate for their stage of asthma based on severity, as we previously discussed. The step one, of course, is intermittent use of a short-acting beta agonist, moving on to low-dose inhaled corticosteroids with alternate treatment proposals, including cromolyn and leukotriene modifiers, phosphodiesterase inhibitors, and moving on further stepwise to more medium and high-dose inhaled corticosteroids, long-acting beta agonists, and alternate medications, including leukotriene modifiers and anti-eosinophil therapy, anti-IgE therapy. Recent modifications includes from step 4 now anticholinergics such as long-acting anticholinergics like tiotropium are also approved for use. And for patients that are step 4 or higher, more recent recommendations propose that bronchial thermoplasty may be considered as a non-pharmacological treatment option. So the asthma yardstick that was published in Allergy, Asthma, and Immunology in 2017, based on the Global Initiative for Asthma Management, Step 5, which is defined as more than 2 oral corticosteroid bursts per year, or symptoms that are persistent more than 2 times out of a year. And the IgE type of asthma, in addition to using omalizumab, BT is recommended as a non-pharmacological treatment option. And so for the eosinophilic type, after a 90-day trial, an alternate therapy that should be considered, that can be considered, is bronchial thermoplasty. And even for the neutrophilic type, as you can see here. So what exactly does bronchial thermoplasty do to the airways that is responsible for decreased symptoms or symptom control in patients with severe persistent asthma? BT is hypothesized to treat the airway smooth muscles, to decrease the bulk of the smooth muscles with and therefore decrease the intensity of bronchoconstriction, thereby improving quality of life. That's the hypothesis. The exact mechanism by which bronchial thermoplasty decreases the bulk of smooth muscle is unknown. So the way that this procedure is described to the patients is that it's an outpatient procedure. It's done as 3 separate sessions, which we will discuss why in future slides. And the energy that is released by the catheter that is approximated to the respiratory tract releases or uses radiofrequency energy, which translates into thermal energy, reducing the bulk of the airway muscles, consequently decreasing the intensity of asthma attacks by reducing the vigor of the bronchoconstriction. This is the system. This is what it looks like. The catheter that we use has 4 electrodes at the tip, and the distance between the 2 bands that you see, the black bands, is equivalent to the distance between the electrodes, the distance covered by the electrodes when it is fully deployed. So this allows for contiguous treatment along the airways. And the catheter is designed to treat all airways that are 3 millimeters or larger. So the radiofrequency controller is a device to which the catheter is attached to, and it has a counter that tells us the complete and incomplete treatments, and it actually times out at 65 degrees Celsius, thereby avoiding any permanent damage to the airways. This is the video that Dr. Shah will help me play. It is going to show an animal model, a dog model, where the airways are treated with methacholine, which is a bronchoprovocative agent. As everybody knows, methacholine causes intense bronchoconstriction. Direct infusion of methacholine on the airway will cause significant bronchoconstriction. As you can see in this video, that the airway on the right-hand side of the screen has intense bronchoconstriction, and the airway on the left was previously treated with the bronchial thermoplasty system. And as you can see, the difference in the caliber of these airways, even with the bronchoprovocation from methacholine. We go back to this slide. Okay, so let's briefly review before we talk about the patient selection on what data that is available. As bronchial thermoplasty as a non-pharmacological treatment option, there are 3 randomized controlled trials. The AIR-2 trial is the largest of all the trials, which included a sham-controlled multi-site pivotal study with 190 patients, and the patients were followed up for 5 years, and the data actually showed that there is 32% reduction in asthma exacerbations requiring systemic corticosteroids, and it also reduced emergency room visits about 84%. And 5 years down the road, this data seemed to be sustained in patients that were treated with bronchial thermoplasty. There was no unanticipated device-related adverse events were noted. The most common adverse event that was noted was asthma exacerbation itself, which happened immediately after the procedure within the first few days. And long-term complications were not noted. If we were to hypothesize that it decreases the smooth muscles underneath the surface of the mucous membrane, it is possible that it would also affect the mucociliary escalatory mechanism and lymphatic transport, thereby causing bronchiectasis over time. But this was not noted by CT scan review. So it is now understood that BT does not damage those smooth muscles. It decreases the hypertrophy of the smooth muscles. So as we discussed a little bit earlier, the immediate side effect that is seen is worsening of the asthma symptoms, which is one of the reasons why we treat them in 3 separate phases and not the entire lung at the same time. So there was no increase in hospitalizations or asthma symptoms or respiratory events over the 5-year follow-up. So what data do we have that shows that bronchial thermoplasty reduces airway smooth muscle and thereby showing the mechanism that was hypothesized as a reason for the efficacy? So the one study that I would quote here is the targeted treatment for airway smooth muscle. Proof of that, and in 17 patients with severe asthma, they did the biopsy on the airways at the carina, and the samples that were noted to be acceptable are the ones that had at least 15% smooth muscles, and they noted that in pre-BT and 3 and 8 weeks later, they noted there was a decrease in airway smooth muscles by 59%, and this also correlated with decrease in exacerbations noted clinically and improved asthma control as determined by the asthma quality of life control scores. The picture in the bottom, the A and B, shows the decrease in the smooth muscles as noted by the biopsy is an example of that. This is an asthma therm study that was done in France. They chose patients who are GINA stage 4 or above. This study is a little bit interesting as they picked patients who are really ill. They picked patients who had FEV1 ranging from 30% to 70%. Please note that the AIR2 trial did not enroll patients with the FEV1 less than 65%. And in my practice, I don't offer bronchial thermoplasty to patients who have severely impaired FEV1 to 30%. However, this study included those patients, and they were always noted to be treatment refractory, including anti-IgE agents, and they all had severe exacerbations. So they would definitely fit the criteria for severe persistent asthma. And these biopsy samples were collected, and on the right-hand side, you can see the biopsy samples that shows decrease in the bulk of the smooth muscles, and they looked at clinical markers for up to 12 months in these patients. So they found out that there was a significant reduction up to 73% of the airway smooth muscles and neuroendocrine epithelial cells after bronchial thermoplasty. And they also noted clinical reduction in severe exacerbations, ER visits and hospitalizations, and quality of life improvement scores. They also needed less oral corticosteroids, and these are really sick patients that they had chosen for the study. So now to the point of this whole talk, how do we establish a bronchial thermoplasty center? What are the components of it? How do we do it? And this is purely my experience and how I do it in my center. Obviously, things can be adjusted depending on the availability and individual needs of different institutions. So be the man, the plan, the clan, and the fan, or the woman bronchoscopist. So we'll talk about patient procedure flow, the team, and each one's role in establishing a center and how to perform the procedure and make it a smooth patient flow, and the referring providers, how do we communicate with them, what do we expect from them, and aftercare. So the way we do it here is that we serve a population that are quite highly educated, so we review the available literature in easily understandable terms to the patient and say why we offer bronchial thermoplasty to severe persistent asthmatics as a non-pharmacological treatment option. We set realistic expectations, which is very important. We always talk about what their expectations are after bronchial thermoplasty. As noted previously, this is a non-pharmacological treatment option. This is not a cure for asthma. It's important to emphasize that it is not a cure for asthma. The expectation is that they would be needing maintenance medications after the procedure. It's important to look at appropriate studies. Important to differentiate between an asthmatic and a COPD. They are two different disease processes, and COPD patients are not appropriate for bronchial thermoplasty. So it is important to look at all the available studies that would ensure the diagnosis in addition to a thorough clinical exam. The fourth point is absolutely important. It is very important to look at the upper aerodigestive tract. What I mean by that is untreated or unrecognized sinusitis or acid reflux is one of the main reasons why I have seen in my practice that bronchial thermoplasty would fail. We never offer bronchial thermoplasty to patients with significant sinus disease that is not addressed, that is not well controlled, and the same thing goes for severe acid reflux disease. If necessary, we enlist the support of and in management of our otorhinolaryngology colleagues and gastroenterologists to help us treat the upper aerodigestive tract before we proceed. The fifth point is also very important. This is, this is probably the most important factor in asthma management. We have to make sure they have proper technique. We have to make sure they are compliant with treatment regimen. We make sure that they address all the environmental concerns. Their sheets are clean, their dust mite issue has been addressed, and their technique is proper. They're using supplemental devices such as spacer devices, and all of those factors need to be thoroughly investigated and understood, that there is no cat sleeping on their beds and things like that. Patients always may not be forthcoming with that information the first visit or so. So we discuss that very clearly and thoroughly understand and truly define these severe persistent asthmatics before we offer the procedure. Contraindications, patients that have a pacemaker because of the radio frequency energy that is being used, fibrillator, or patients who are allergic or sensitive to medications that they cannot use it, that is typically needed to perform bronchoscopy, and patients that have been previously treated with the bronchial thermoplasty system are also listed as a contraindication by the manufacturer. These are common sense things. If there is an active respiratory tract infection, you don't want to subject the patient to bronchoscopy. And if there is any up or down mobility of their medications, they need to be in a relative steady state for them to undergo the procedure. So even if the patients are on chronic steroids, we advise them to have them be on a low dose for the entire 6 weeks, except for the pre and post procedure corticosteroid that we use at 50 milligrams 3 days before and 2 days after. Obviously, if they have a known bleeding disorder that cannot be controlled, they may not be good candidates for the procedure. There's typically not much of bleeding with bronchial thermoplasty. However, we do know that an asthmatic airway is quite hyperemic and inflamed, and so small capillary bleed is expected. Of course, if they have a bleeding disorder, that can get worse, so they will not be candidates. And if patients are unable to stop their anticoagulation for any reason in order to go through the procedure, are not candidates for bronchial thermoplasty. So we talked about the equipment, the Alair bronchial thermoplasty controller and the bronchial thermoplasty catheter. We talked about the markings on the catheter that is equivalent to the deployed electrode, which allows us to provide contiguous treatment along the airway, and the intention is to treat all airways that are 3 millimeters or larger. We do a pre and post procedure spirometry, and we see if the patient gets to at least 80 to 85% of the pre-procedure FEV1 is one of the criteria, not a sole criteria that we use for as discharge. We monitor those patients in the post-bronchoscopy suite for at least about 3 hours to make sure that they are not having exacerbation. We think that the performance of pulmonary function study and spirometry is dependent on the relationship that the technician and the patient has, and therefore consistent results are usually generated by the same tech performing the PFTs pre and post. So we make sure that the same technician performs the pre and post spirometry for the patient, because the instructions and the flow itself is better if it is that interaction is the same. The procedure can technically be considered can be done with moderate sedation using a benzodiazepine and a narcotic. However, I do it under anesthesia with deep sedation for a couple of reasons. One is that anesthesia allows me not to be in contact with the airway too much with the scope, which these airways are highly provocable and the likelihood of exacerbation is more. And the second thing is, if during the procedure the patients have bronchoconstriction, I can interrupt the procedure, give them an inline nebulizer, and proceed with the procedure so that I believe that because the hypothesis is that you treat the maximum number of airways, 3 millimeters and larger, and the idea is to decrease the bulk of the smooth muscles in the submucosal area, the more airways that you are able to treat, the better the outcome is going to be. Therefore, having a patient under anesthesia allows you to do that. If the patient undergoes a significant bronchoconstriction during the procedure, you can interrupt the procedure, give them an inline nebulizer, allow the airways to open up, and complete the procedure, and therefore you're providing a better service for the patient. So my recommendation is to do it under anesthesia for those reasons. To ensure smooth flow, it is important to think about pre-procedure order sets. Most institutions now have electronic health record, and therefore it's easy to put order sets that are specific for the procedure. We always, indicate the anesthesiologist can review these order sets. In case we give glycopyrrolate before the procedure, the anesthesiologist also gives glycopyrrolate during reversal, and we want to make sure that the patient doesn't have urinary retention, comes back 3 hours later to the emergency room with a distended bladder and needed to be straight capped and causes a lot of discomfort. These things can be avoided by having these order sets. We use Solimedrol on the day of the procedure. Those order sets can be in place so that the nursing staff knows for a specific bronchial thermoplasty patients, the X, Y, Z marks have to be checked. The steroids are in, glycopyrrolate is in, anesthesiologist notified about that, and all of those order sets, pre and post procedure spirometry orders, can be generated so that the patient flow is smooth and consistent across all patients. So we have looked at this before. We make sure that there is no respiratory infection or up and down mobility of medications in the 2 weeks before the procedure. We use 50 milligrams of prednisone 3 days before and 2 days after the procedure, and then they go back to their previous medications. We also give IV Solimedrol on the day of the procedure, 125 milligrams. And we talked about the spirometry, and we talked about the moderate sedation and anesthesia and the advantages of anesthesia. This is a personal recommendation. This is a scope, the MP160, that actually has a smaller outer diameter and allows you to get into various airways and able to treat as maximum number of airways as possible. A diagnostic scope is preferable over a therapeutic scope if you're from some reason don't want to use this scope, because a smaller scope with a good working channel gives you better access to as many airways as possible that you can treat, which I believe gives the patient a better outcome. So the BT team, we have a dedicated assistant to do the procedure, and we always use this airway map that I have on the right-hand side of the slide. We always have a particular pattern of treating the airways. The first procedure will be the right lower lobe. 3 weeks later, we treat the left lower lobe, and 3 weeks later, we treat the bilateral upper lobe. We do not treat the right middle lobe, and we always treat the airways from distal to proximal and lateral to medial. You can use whichever format that works for you, but to be consistent in doing it one particular way actually helps you complete the treatment without missing any segmental or subsegmental airway. We start in the right lower lobe, for example, RB 8, 9, 10, which is anterior, lateral, and posterior, and we go 8A, 8B, 8C based on the subsegments, and those things are marked on the chart and on this in this cartoon that we have this airway map for every patient, and it is documented by a separate assistant. And then at the end of the procedure, the total number of treatments, complete and incomplete, are tallied based on what we see on the counter, and then we match it with each other so that it's a good record keeping. You know how many treatments that you gave for each patient, and it also has a consistent method Therefore, you're not really missing any airways if in case you have to interrupt the procedure for some reason. If you want to take out the scope and do suction or clean up the catheter because it's covered with mucus or small amounts of blood, all of those things, if you have this systematic pattern of treating the airway, this would help you when you get back to where you left out. So that's basically how we do the procedure. I would like to finish up by giving you some case examples. I picked these cases for particular reasons, and I will tell you what they are. My first case example that I would like to present to you is a 31-year-old world-class athlete, a sports star who has had asthma since childhood, and has been on and off medications from age 8 to age 13. This person grew up in Arizona, moved to New York, is part of a big team. And as this person became older and older, the asthma symptoms were worse and worse. And he was on multiple medications, including Advair, at high doses, and short-acting beta agonists, and increasingly needed more and more Medrol packs. So this was affecting his game, and it was a big problem. And most people, including the patient, thought that his career was over. Now, you would ask, why would you pick a patient, a world-class athlete, for bronchial thermoplasty? Now, that's an interesting question. So our goal in treating bronchial thermoplasty is to make sure that the patients can get back to their activities of daily living. Now, this person's activity of daily living is different from all of ours, I'm sure. One of the interesting things to me is that for this person, a pre and post exercise spirometry showed that there is more than 30% reduction in FEV1 post exercise. So remember, we discussed the three pathobiologic aspects of asthma, and it was difficult to determine which aspect is dominant in a particular patient. Now, in this case, it was pretty clear that his bronchoconstriction was a big factor, and therefore, we thought bronchial thermoplasty is a reasonable option for this person, as he had tried all kinds of medications and increasingly been on steroids, and therefore we did a bronchial thermoplasty on him. The bronchial thermoplasty is in 2012. We did 91 treatments in the right lower lobe, 66 in the left lower lobe, and bilateral upper lobe. We did 117 treatments. Procedures went smoothly. There was no adverse events, and this person went on to reach greater heights in his career, and is still doing well. So, subjectively, at least he credits the benefits that he's seeing to the procedure he had. Is not on any steroids. Still needs bronchodilators, but one of the interesting things that I wanted to do was repeat another post procedure, pre and post exercise spirometry. However, after the procedure, it was kind of difficult to get hold of this person, understandably so, because of the extremely tight schedule that this person has. So I was unable to do that. However, subjectively, at least he feels better and is able to get ahead with his career. Here's the next patient that I would like to present to you all. This is a 30-year-old school teacher, had asthma for many years, is intubated twice, and had at least 1 or 2 ICU admissions per year. So truly a severe asthmatic. She's been on every medication that you can think of, high-dose inhaled corticosteroids with long-acting beta agonists, anticholinergic, leukotriene modifiers, cyclosonide, nasal steroids, antihistamines, as-needed albuterol, proton pump inhibitors, also Xolair. Still had multiple exacerbations, and preserved pulmonary function. As many of you already know, that a severe asthmatic patient can even have normal pulmonary function between attacks. And the patient was on prednisone on a daily basis. So we thought she was a good candidate for bronchial thermoplasty, and we again treated this person also in 2012. These are the number of treatments that you can see in the bottom of the screen. And we have her picture here with her permission. She significantly improved after bronchial thermoplasty. She's still on Xolair for allergic symptoms. She has not had any hospitalizations. She has been not on any steroids since the procedure. She's still on high-dose inhaled corticosteroids and long-acting beta agonists. She occasionally needs short-acting beta agonists also. And with the Xolair, she would still meet criteria for being called a severe persistent asthmatic. However, her quality of life and not having a steroid burst or being on continuous steroids is a big improvement in the quality of her life. She actually did the Tough Mudder competition and went on a skydiving expedition also, and so those were good improved quality of life for her, and we were certainly happy that her quality of life had improved after BT. So this is a third case example that I would like to share. It was a 66-year-old lady with severe asthma and had asthma since childhood. The interesting thing about this patient is that she's one of 3 triplets, and 2 of them have severe asthma, 1 has mild asthma. She, at the time of evaluation, was on high-dose inhaled corticosteroids and long-acting beta agonists, leukotriene modifiers, anticholinergics, nasal steroids, proton pump inhibitor, and anti-allergy medications, and on continuous medications or prednisone for greater than 5 years at the time of evaluation. So we did the BT treatment, and she did quite well. And after the procedure, she actually recommended this to her sister, to the second of the 3 triplets, who also had severe asthma, and I treated her as well, and she did well also. The interesting thing is that the first patient that I was telling you about, she started having some nocturnal cough and had exacerbation. After feeling really good for a year, she started having exacerbation and having nocturnal cough, and she was producing some early morning sputum, so I was worried that she was developing bronchiectasis. So I did a CT. What I noted was interesting that she had a small hiatal hernia before that was noted on a previous CT scan. And for some reason, her hiatal hernia has gotten significantly worse, and she was having reflux. And that was the reason why she was having exacerbation. So I sent her to a surgeon who laparoscopically repaired her hiatal hernia, and her asthma was under better control afterwards. So this again goes back to my previous statement that the most common reason why I have seen asthma, bronchial thermoplasty fail and asthma exacerbations happen afterwards is untreated upper aerodigestive tract. This is that patient. With their permission, I have their picture here, and as you can see, they are very similar, and the only way you can tell them apart is the color of their hair, and they deliberately do that so that they can be differentiated. So she definitely and her sister, who had severe asthma, ended up doing well. She didn't have any exacerbations afterwards, and she continues to do well almost 5 years out. So with this, I conclude my presentation, and I'm happy to answer any questions that you may have. Thank you.
So at this point in time, we'd like to turn it over to questions, and Ara and I will be moderating that.
Yeah, sorry, I was on mute. I apologize.
No problem.
Talking to myself over here. So yeah, thanks, Dr. Krishna, for that excellent talk. So we do have a few questions here that we can move into. The first one is asking if there's any data for, do you have any particular experience with patients that have the so-called asthma COPD phenotypic overlap? And if I can add on to that, in general, do you think that certain phenotypic asthma clusters respond better to BT than others?
Yeah, that's an interesting question. So I'll answer the last one first. So it is difficult to determine what phenotype an asthmatic is. I mean, which aspect of asthma is a dominant factor in someone? We are not entirely sure, and in most patients, it's a cluster of a few things that are happening. Asthma phenotyping is still an elusive topic, and there is no clear-cut determination of who is what. So at this point in time, there is no clear particular type of asthmatic, unless, based on the case example you saw, there was one that was really standing out in the form of the world-class athlete who clearly had bronchoconstriction as a primary modality by which his asthma was exacerbating, and we were able to offer bronchial thermoplasty for that reason. However, there are other patients who have benefited as well, and therefore, for us in terms of patient selection for bronchial thermoplasty, they really have to be a severe persistent asthmatic to whom we offer this as a non-pharmacological treatment option. And the second question is, is there any data on, I'm sorry, can you refresh my memory here? What was the second aspect of that question?
If you have any experience with, or if there's any data
COPD,
for patients with asthma COPD overlap.
Right. So the asthma COPD is a different issue. It's like, so, we think that over time, an asthma patient from having a pliable reversible airflow obstruction to fixed airflow obstruction, possibly due to submucosal fibrosis and whatnot. We don't have that, exactly how that happens. However, if the patient has been an asthmatic, and if they don't have a significant airflow reversal, that does not exclude them from bronchial thermoplasty. I do not exclude people just because they have a poor reversibility with a one-time administration of bronchodilator during pulmonary function testing. Having said that, I think we do make an effort to determine if the patient has asthma or COPD. For example, if they have smoking history, if they have emphysema-based CT scan, if they have severely reduced diffusion capacity, all of those things kind of point more towards the emphysema, chronic bronchitis, COPD, the pattern. So those patients, that pathobiology is different. So we do not offer bronchial thermoplasty to those people. When in doubt, we do additional studies. We do CT scan of the chest and make sure that they are appropriate candidates before we proceed.
Excellent. Thank you, Dr. Krishna. Next question addresses the insurance issue. Any thoughts and insight into the current insurance coverage climate, both locally and its variability across the United States, and any insight into overcoming obstacles for coverage?
Yes, that's another very interesting question. So the way it is in my experience is that about I would say about 50% of the insurance companies, the third-party payers, approve this. Another maybe 10-15% will approve if you appeal, and so we have an appeal process. We present the data, and we have secured approval after appeal in several patients. And then there's about 30-35% of insurance companies will not approve it no matter what you do. So I think that is a kind of expected norm for anything that comes out new, especially if it is a procedure. And as we see more and more of these patients, as we collect data and publish and discuss this more in professional meetings and be advocates for these patients, if we truly believe that it is beneficial for our patients, it may eventually get approval from other third-party payers that are currently declining payment. However, I think the key is to collect data and publish and have more experience and demonstrate that more patients benefit, and perhaps maybe even identifying the right patients beforehand, the phenotype, so to speak, that would benefit may also help.
Excellent. Another question from the audience is asking your experience with your patients requiring overnight hospitalization immediately post bronchial thermoplasty, whether it's due to an asthma exacerbation or for other complications?
Sure. Yeah, we have done a little over 200 procedures. I have probably I think I have admitted maybe 2 patients in that, and that too for a short time period, maybe 2 to 3 days max. And this is always because of bronchial asthma exacerbation. The overwhelming majority of the patients do go home, and however, I do observe these patients much longer than my other interventional pulmonary cases, including central airway obstruction, airway recanalization, and patients like that. These patients are always observed for a minimum of 3 hours after the procedure, and we do a post-procedure spirometry before we send them home.
Excellent. Getting a few more questions here. This one is particularly about the effect of AICDs and permanent pacemakers on candidacy. Specifically, does RFA energy interfere with these devices, and should we take any special precautions?
I do not personally believe that the RF energy interferes with the AICD pacer. However, it is the manufacturer's recommendation that we do not use in that patient population, and therefore we follow that. Obviously we can look at this in a more formal setting with local IRB approval and look at this, which we have done in other devices such as electromagnetic navigation, for example, which is also a manufacturer recommendation that we don't use the AICD pacer. However, there have been studies that have been published, so similar things can be done with BT also. However, I would point out that that particular patient population is very different from an asthmatic. It's not very often we see a severe asthmatic with also a pacemaker. That's a different physiology altogether. It's very rare to have that overlap, but my thoughts are that at this point we follow the manufacturer recommendation, and outside of a clinical trial setting with proper institutional approval, it should not be done.
Great, thank you. Moving on, yet another question. We know that bronchial thermoplasty, of course, treats the larger airways. Now, asthma, of course, is classically described as a small airway disease. Is there any evidence of smooth muscle mass reduction distal to the treated airways?
Well, first of all, I think that's it's debatable that asthma is a small airways disease. The data that describes asthma as a small airway disease is based on airway biopsies and looking at neutrophils in small airways. Are postmortem studies that shows airway plugging in small airways. That I don't believe that is the case. I believe asthma is a disease of the airways. There is bronchoconstriction in all airways. And the system itself is designed to treat airways that are 3 millimeters or larger. So the definition of a small airway is 3 millimeters or smaller. So that's basically how we treat. And it is there are 17 to 25 generations of airways, and we don't necessarily know what percentage of small airways and what percentage of 3 millimeters or larger airways in any particular person. So that's kind of a tricky thing. And I've been asked questions as to why do people still have airway hyperreactivity if you're treating these patients with bronchial thermoplasty? And my typical answer to that question is, well, we're not treating the entire tracheobronchial tree. We don't know the contribution of bronchoconstriction of the small airways smaller than 3 millimeters versus the larger airways. So it is important to remember that we are not treating the entire tracheobronchial tree. And that's the reason why we focus on treating as many airways as possible and try to offer the patient the best possible outcome.
Yeah, I found it interesting that at least in a few studies, there's data showing both histological as well as radiological changes and effects in lobes that haven't been treated, such as the middle lobe. Any thoughts on the cause and implication of these findings?
Yeah, so the advisory committee recommended that we don't treat the middle lobe, and the reason is not very clear to me. However, yeah, the airways that are not, it will be interesting to look at various things. For example, exhale nitric oxide is selectively in the middle lobe versus the other places, and airway biopsies and smooth muscles. I don't know if there is a specific study, Era, I don't know if you're aware, but I don't know if there's any specific study that compared airway biopsies from untreated segments in the middle lobe and another place in the same patient. I'm not aware of any such data.
Yeah, there were a couple recent histologic examinations done in bronchial thermoplasty patients, looking at both middle lobe as well, untreated middle lobe as well as treated segments, and it did look like there were some smooth muscle effects even in the untreated areas, which was interesting.
It looked like there was smooth muscle effects in the untreated areas as well?
Correct.
Oh, okay. This is how long after BT?
I believe, I don't know that off the top of my head, but it was within the usual change period, so I sometime within 12 weeks, I believe.
That's interesting. You know, we always thought that the reason why we provide contiguous treatment using the bands on the catheter is to make sure that, you know, the treatment is continuous across all the airways. It would be definitely an interesting thing to note that untreated airways also have smooth muscle reduction. That would be interesting. I'm not aware of the data, so I'm sorry I'm not able to comment on it.
So we have a few more questions here. I do want to focus on one that is a topic that frequently comes up when discussing bronchial thermoplasty, and specifically the AIR-2 trial. The placebo effects. We know that it was a sham controlled trial, and within the sham group, we did see some placebo effect. What is your thoughts on those results?
Yeah, I mean, surely, you know, that thing would be a consideration, would be something to discuss in the initial trial. However, I would point out that they also showed that it kind of persisted over 5 years, and I highly doubt that that can be attributable to placebo effect. That those effects continue to be demonstrated over 5-year follow-up. That would be difficult to claim that it would be all placebo.
Excellent. One of our audience members, Dr. I think it's Giuliani, I apologize for mispronouncing if I am, is trying to start a program in India. Any thoughts on how to enroll the first patient? Initial advice on getting started?
Well, again, I think it's very important to So again, I would go back and say bronchial thermoplasty is a non-pharmacological treatment option for severe persistent asthmatic. It is not a cure for asthma. It's very, very important to address environmental factors, compliance with treatment, inhaler techniques. So there is a lot that we reject more patients that are referred for bronchial thermoplasty than we accept, because we always find that there is something that can be improved in their care. And we continue to follow them on a peripheral basis with the referring provider to make sure that those issues are addressed. If those issues are addressed, and if we know that these are severe persistent asthmatics who have realistic expectations, that have their environmental factors and their aerodigestive tract and their technique of use of inhalers review, asthma education has been provided to them, then I think it is you can offer BT as a non-pharmacological treatment option. And we talked about the constituents, your team, and the setup, and you have to be cognizant of the fact that you have to do it like 3 weeks apart in 3 procedures, and you're treating them with corticosteroids. So monitoring these patients on a continuous basis over a period of time is very important. So congratulations on the idea of starting the BT program, and best wishes.
We have one more question that I think I had missed here. What is your approach to patients who have developed either have emphysema or develop emphysema? Again, this is probably piggybacking on to the previous question about asthma COPD, but specifically emphysema, is this a patient demographic that you automatically exclude, or are there exceptions?
I think emphysema is a totally different disease. I mean, they all come under the classification of obstructive airways disease, but emphysema is a very different entity. It's protease antiprotease imbalance, and there is air trapping. There is loss of alveolar capillary transfer interface with reduction in diffusion capacity. It's very different from asthma as a disease, and therefore, in my practice, there are no exceptions. If you have emphysema, I do not offer bronchial thermoplasty. The system is not intended to treat emphysematous patients.
Excellent. If there are there any other questions from the audience? Okay, looks like we have one from Mel Imad. It reads that it asks, is there any data on patient selection with an post-bronchodilator FEV1 of less than 65%? And are there any personal recommendations to enrolling these patients?
Well, the data was the asthma therm study that I showed you. They picked patients FEV1 for 30% or more. So those are really sick patients. They didn't report any specific adverse events in those real sick patients. However, I would like to point out that this is a very small number. In my practice, I have not done BT in patients with an FEV1 of less than 50%. I'm reluctant to pick patients that are severely impaired lung function, primarily because I have my reservations as to whether BT would help them or not. And when I'm not sure if a procedure is going to help someone, I'm not going to offer it.
Great. Thank you very much. It looks like we've reached the end of our hour. Dr. Shah, any closing remarks on your end?
Nothing specifically, but I do want to thank again Dr. Krishna for lending his time and experience to us for this past hour talking about bronchial thermoplasty.
Thank you.
So otherwise, Ara, I guess we'll go ahead and wrap up the hour at this point. So we appreciate everyone joining us. We'll go ahead and stop the recording.